is going to be higher. The reserve in the asthma patient is going to be higher. Let's not write it down. Let's listen to this. It's more easy to understand. You ask questions if you need to ask any questions. Okay. So the reserves in the asthma patients are much higher than that of the COPD patient. This is first very important. Huh? So very difficult to go ahead and kill an asthmatic patient. You know, because the reserve is very high. Okay, that's why these asthmatic patients you might get very high pulse rates when they are coming to you. They will look like they are going to die the way they are, breathing very heavily. They are agitated. It's very young people. Okay, and literally it is like suffocating themselves because they can't, as you rightly said, move in air or move out air. They are unable to do that. So it's like suffocation. So they can't take in air or take out air. So it's like you getting into the water and water getting into your mouth and your nose. It's like that, as bad as that. So that's why asthma needs to be treated in a different way as compared to COPD. Okay. Now the first thing is, what are the indications for initially even intubating it, or for that matter, when will you call it as severe? When will you call this as this patient is probably going to be severe? He's going to be severe if he's going to be showing an excess work of breathing. So clinically you should have the look that this patient is having an excess work of breathing, because ABGs are not great tools. Now why is it not a great tool? Because when you have a patient of COPD, he may initially have a carbon dioxide that is on the higher side. So what are you going to look at? It's not something you can look at. Similarly in asthma, a pH of 7.4 with a PCO2 of 40 and a PO2 of 80. Who says this is normal? Is this normal or is it abnormal? What do you feel? If you have an asthmatic patient, I'm putting up the pH is 7.4. The PO2 is 90, and he is breathing heavily, and his PCO2 is 40. Huh? What do you think? This is normal?
No, sir.
Who says? I mean, it looks normal.
It looks normal. The clinical
But work of breathing is
patient is breathing heavily.
so it is not normal.
Sorry.
CO2 should drop more.
So correct. So ideally what you have to have, if a person is hyperventilating, the PCO2 should be in 20, 17, 12. The very fact that if your PCO2 has come to 40, it basically indicates what? That the patient is tiring out. That the patient is tiring out, he is unable to take in air or take out air. So it's a very false sense of security if you cannot interpret that ABG. If that ABG shows PCO2 of 40 or 35 for that matter, it is really bad. This patient is one of that patients that very quickly is going to get intubated. Very quickly. He is exhausting himself. So one of the prime reasons why you intubate a patient is because of exhaustion. Okay, they become tired. They become tired because they just can't move in air and move out air. Why they can't move in and move out air, if you ask me? There are multiple reasons why they can't move in and move out air. Okay, one of the reasons is that that's where the pathophysiology comes in. So when you have asthma or COPD, because of the fact that they can't expire out air because of obstruction, and expiration is always passive, it's not active, isn't it? So at expiration the airways are becoming smaller and smaller because it's passive. Air has to move out. Unfortunately, the air is not moving out. Since the air is not moving out, the air is accumulating inside the lung. The lung is getting more and more expanded. The lung is getting more and more expanded, and that is why the pressure in that lung is going higher and higher. Okay. Now, once the pressure is going higher and higher, what is also happening is, because the pressure is high, in order to actually generate the flow from outside to inside, he needs to take more pressure. Otherwise, the negative pressure will not come in because there's already some pressure inside. Okay. If he has to move air from outside to inside, he has to first go below this pressure, and then he has to take in air. So that is one problem. The second problem that you have is when the diaphragm becomes lower. Okay, because as the volume is increasing, what is happening? As the volume is increasing, the lung becomes flattened out, right? It becomes flattened out compared to what it was like this. Compared to what it was like this. You understand? Huh? This is what it is. Normally, what you have, the diaphragm to be like this. Okay, dome shaped. Now, what is happening in our asthma or COPD patient? This is becoming flattened. So the distance to expand the lung, the distance that it requires, which will get the lung down, that is reduced markedly. Okay, so he's unable to pull in air from outside because the mechanics of the diaphragm has changed. The mechanics of the diaphragm has changed. So the amount that the diaphragm goes down is so less that it cannot expand the lung. So that is what you're going to see clinically. Clinically, when you have a patient in front of you, okay, and you are not seeing any minimal chest size also. What does that mean? That means that patient is unable to take the breath. It's not that he's okay. If the person is so heavily breathing, that is RR is 45 and his chest is not expanding. What does that mean? That means the PEEP inside, the auto PEEP inside is so much that his diaphragm has gone down, mechanics has worsened and he is unable to move in air. So clinically what you're going to see, you're going to see this patient, so that's why I'm saying, because the blood gas is not in our hand. Na? Blood gas will only tell you terminal stages. If the PCO2 is 40, he's going to get intubated. If the PCO2 is 40, he's probably going to get intubated. So we have to catch it before that. No? So what you're going to see clinically you will find this patient to have very low chest expansion. To an extent, and when there is very low chest expansion means he's unable to move in air from outside to inside. This will relate to you as a silent chest. This will relate to you as a silent chest. Because what is going to happen over here? There is no air movement. So you put your stethoscope and you can't hear air. If you can't put stethoscope and you can't hear air, what are we dealing with? We are dealing with a condition where the patient is unable to ventilate himself. Okay, so don't look at that saturation. Don't look at that saturation. Saturation is going to be remaining like that for a long period of time. You understand? You understand? So saturation again is not a great tool to see for intubation. Saturation again is not a great tool because saturation dropping is terminal. We have seen it so many times that you have switched off the ventilator also. There is no air going, patient is brain dead, but saturation remains steady. Actually the heart stops, even after that it remains for some time because pulse ox nahi hai to saturation nahi dikhta, utna hi hai. But saturation remains for a long time. So saturation is not something you're going to look at. So if you say saturation is hypoxemia, I'm going to look at? No. You understand? I'm not going to look at hypoxemia. Because if you start looking at hypoxemia, you're gone. If you start looking at hypercarbia, again you're gone because you're not going to do the blood gas. So if you're looking at hypercarbia, if the PCO2 is 40, I want to intubate, I'm not really looking at that. You understand? So ABG, if you are looking at it, even if you're drawing the ABG, you should be aware of what we are dealing with. In asthma, hypercarbia is 40 or normocarbia is dangerous. In COPD, we don't know what is happening only. Okay, so in COPD we take this kind of a situation that if the PCO2 has gone up acutely, the pH if it is dropping to 7.1 or 7.15 or 7.2, maybe this is because of hypoventilation. This is because of CO2 retention. But that patient will actually have clinical symptoms. And what will be the clinical symptoms? One, what you said, altered mental status, patient getting drowsy. You understand? So you have to correlate your blood gases to what is happening clinically. Okay, so if you have a blood gas, you are doing it, say for example, because you want to do a baseline, you have to correlate that to the condition. So if the PCO2 is 40, is his chest wall rising? It's not rising. So this is not good for this asthmatic patient. Patient's PCO2 is 80, is a COPD patient, but patient is getting drowsy. This is actually part of COPD exacerbation or CO2 narcosis, right? So you're going to look like that at your patient, and then you will take a call on intubation. So the intubation basically depends on the work of breathing. It actually depends on the work of breathing, because as they go higher on the work of breathing, because they are unable to breathe like this, they are higher and higher on the work of breathing, they will get exhausted, and they will get intubated. Clear? So we don't want to come to that condition where the patient is having bradycardia. If he goes, imagine this, when a person cannot breathe, you know, if you don't know swimming and you are put inside water, how the way you will jump about, it's dangerous, right? The way if somebody smothers you, what will happen to you? The way you will move, you've seen that in movies, how they move, right? This person is like smothering, and at this time, what will be your pulse rate? Your pulse rate has to be 150, 140, 130. You understand? The time if your pulse rate starts going down means this is very arrest. If it is 60 and 50 and which is normal, if it is 62 you will say it's okay, but 62 is not okay. This patient probably has got a sympathetic overdrive. Okay, but your pulse rate is 60. This means to say what? This patient is going to arrest. We cannot go at that moment and try to intubate. That is very wrong. We have to decide the intubation much earlier. Are you getting the point? And that's why, most importantly, if a person comes to you with an acute exacerbation of asthma or COPD, Your bedside presence is the most important thing. Your bedside assessment is the most important thing. For example, if he comes with the RR of 40, okay, and now you've put up on whatever you medicines and whatever you're given, and in 1 hour's time, the RR comes from 40 to 38 and is clinically improving, or 30 and is clinically improving. You're okay. It remains at 40, is not clinically improving. This is a patient you need to intubate because your 1 hour treatment has not helped. 2 hour treatment is not going to help you. He needs time because the reason to intubate is not to save life. The reason to intubate is to give time for the drugs to work. The reason to intubate is what? To give time for drugs to work. समझ में आ रहा है? It's not, you are not intubating to save some life here. You are intubating because in the big picture it will save life only. But we are intubating why? Because we want to. This is a very important word. Why is this so important? Because I am not doing that intubation to improve a saturation or improve a carbon dioxide. This is what you must remember. This is what you must remember. Okay, if I get a PCO of 80, if I get a PCO of 80, I am not intubating to get that PCO2 to 60. I am not doing that. This is what you must understand. If I am getting a saturation of 88, I am not intubating to get that saturation to 94. No, I am not doing that. What am I doing? I am only generating time and keeping him alive for this period, so that the drugs can work. Because if I don't do that and I try to do something like this, what can occur? Can you ask? Can you tell me what will happen if I actually intubate and try to raise the saturation? What will occur? Sorry?
The COPD patients has pulmonary hypoxic constriction, so it will not work because it works when the saturation is at 88 to 92%.
What is this thing? She's talking about something called hypoxia. What is this? What is going to happen if I give too much of oxygen? Sorry?
Carbon dioxide in the water loss and free radical injury. Weaning will be difficult.
You said weaning will be difficult. You said free radical injury. You are saying what?
Hypoxic pulmonary vasoconstriction.
So what will happen if you give oxygen?
That will get
That won't be there.
So what will happen to the patient?
failure.
It will get better, no? Because if hypoxia is coming off.
There will be CO2 narcosis. Patient will not respond that.
What will happen? I mean, you told me there is hypoxia. What will happen? You are understanding my question?
Yeah.
You just now you kept saying hypoxia will release, but what will happen? So let me explain to you. Okay. So let's take the alveolus. Let's take the alveolus. Okay. And let me say this is one of the alveolus that you have. Okay. Let's take another alveolus, which is basically, what is the meaning of hypoxic? This alveolus is not getting any air. This is meaning of hypoxia. So you have one alveolus that is inflated, and you have another alveolus that is dropped down. This is exactly what's happening inside this particular patient because there is obstruction in this airway. There is obstruction in this airway, and the air takes the path of least resistance and it's moving like this. What is happening because of this? This area is dilated with the pulmonary vessel. Okay, say pulmonary vessel is coming from here, and this area is constricted. This is body's defense mechanism. This is body's defense mechanism which actually causes that the alveolus that does not receive oxygen, that vessel will vasoconstrict. This is called as hypoxic pulmonary vasoconstriction, so that I don't waste this. If this was dilated, what will occur? If this was dilated, what will occur? There is nothing coming from here. So this will become like a shunt. This will become like a shunt. So it is reducing the shunt. By doing hypoxic pulmonary vasoconstriction, it is reducing the shunt or the deoxygenated blood from mixing with the entire circulation. Are you understanding? Now let us take the example of you ventilating this patient and increasing the oxygen. Okay, so you had 88 and you decide to make it 93, for example. What is going to happen? So what happens with oxygen is going to diffuse inside, no? Oxygen is going to diffuse inside, but there's a huge amount of carbon dioxide that is lying inside. Because it's not able to move in and move out air, na? Air is going inside but not coming outside. It's not coming outside. So the air is accumulating and that air is carbon dioxide. Because this is working very well, no? This is working very well. Since that is working very well, the carbon dioxide is getting accumulated in that. Now once you give oxygen, The oxygen is moving inside. The amount of oxygen is going inside, but the this is remaining the way it is. The obstruction remaining the way it is. Oxygen is going inside. You increase the fraction of oxygen. You not flow. Increase the fraction of oxygen because you want to get up the the SpO2. That's what you did. You made it 100% of oxygen. What is going to happen? The fraction of oxygen is going up means the amount of oxygen reaching down is going to be higher. You are understanding this? So if the oxygen reaches higher over here, what is really going to happen here and here? The fraction of oxygen is going to work. This will not see there is no hypoxia here. What will it do? It will dilate again. It will dilate again. You understand? Once it dilates, what is going to happen? The shunt is opened up. The shunt is opened up. When the shunt is opened up, this is going to deoxygenate your patient. Patient will go down. Are you understanding? Patient will go down. This is what is going to occur. Are you understanding this? Patient will go down. So you will release the hypoxic pulmonary constriction. Also, there, if you go, when we did physiology in Guyton, there was something called the Haldane effect. What is the Haldane effect? The Haldane effect said deoxygenated blood carries carbon dioxide more. Deoxygenated blood carries carbon dioxide more. Now what is going to happen? You are oxygenating that blood. So the carbon dioxide movement in fact worsens. You understand? So your PCO2 which was actually 70 will now become 100. And this is what you are regularly going to see on your blood gases practically. Practically what is going to happen, the moment you put your patient on a ventilator, you have improved some amount of oxygenation. Some amount of you have improved, there is no doubt about it. There is some oxygen that is going to go inside from otherwise. It was 21, it was 21%, 30% or 40% which was going on. You have increased the oxygen. You are going to release hypoxic pulmonary vasoconstriction. Haldane effect is going to come. The next blood gas will show 100. The blood will show PCO2 of 100. You are understanding? That is going to occur. That is not failure of ventilation. It is what is physiology. So unfortunately, if you don't understand this, what is the next step you will do? No. What is the next step you will do? PCO2 100. You will increase the RR. If you increase the RR, what is going to happen? The auto peak will increase. So it will become the cycle. You understand? What will happen is, you will see that okay, saturation was 88. I have now increased the saturation to 90% by increasing my FiO2. Now I get my blood gas. I want to do my blood gas. क्या हुआ मेरे ventilation से क्या हुआ करके तो blood gas कर लिया. Blood gas कर लिया. FiO2 saturation has come up. Saturation is 102 and you have a PO2 102. But the PCO2 from 80, 70 has gone up to 100. Now you say 100 PCO2. I am scared of this. Let me increase the RR. You increase the RR. What's going to happen next step? Auto peak. And next step is BP going down. This is the cycle that you normally see if you don't understand pathophysiology. This is the cycle you normally see when you don't understand pathophysiology. Okay, and this is exactly what happened with one of our patients on bed number 9. She is now ventilated now. That patient on bed number 9. Yeah. This is exactly what happened. No? What did you do? You have this patient who was having problems by and what do you do in the middle of the night? You ambu back that patient. You ambu back that patient. What happened after that? The blood pressure dropped. Next day morning, patient was on 12 of NORAD, vasopressin of 2. Everything all hell broke loose, isn't it? That's what we did in this case. We increased the auto peak there. When she had a bronchoconstriction. You shouldn't have done that. You shouldn't have gone ahead and tried to bite the patient because the saturation is going on, the PCO2 is rising. Give her time. It was the answer. Let the drugs work. Isn't it? She was not dying at that time. You actually put her towards death by doing this. You understand what I'm saying? So you've understood why why this problem is occurring of release of hypoxic pulmonary vasoconstriction, right? Clear on this? So now the big question that comes over here is, okay, I have this patient whose work of breathing is deteriorating. Okay, he is getting more and more drowsier. I need to intubate this patient. So there are a lot of different things that you will do in these cases. So now, at least now you've understood over here, failure of NIV is one. Hypoxia and hypercarbia is very questionable. You don't know what to do. So you can't just label as hypoxia, it's very questionable. Tachypnea, yes, very important, but level of consciousness is most important here. Okay, so and we also discussed some more ways to understand. So chest expansion. Okay, tripoding. What is tripoding? What is tripoding? No, tripoding is, what is tripoding?
Start to breathe out very
How,
fastly.
that means you have not seen patients with asthma. How does a patient with asthma present? How? No. Tripoding क्या होता है? You have not seen it. Tripoding में क्या होता है? वो दोनों हाथ से आते हैं. देखिए बस. They don't sit like this. They sit like this, no? They sit like this. Because they just want to open their lung. They want to open their lung. Since they want to open their lung, it becomes tripoding. Okay, if you put like this, so it's the same policy when you're running. No? You've seen patients, people running on the marathon. How do they run? They run like this. Nobody runs like this. Why? They want their lung to be bigger. To improve their lung expansion, they normally will sit like, they will never sit like this. They will never sit like this. They will not get the neck down. They want the air to go in. They'll always be like this. They'll always be like this. They'll always have their hand like this. It's very important you realize that. Okay, what is happening? This is called as tripoding. This is called a tripoding. So now you realize that clinically you must understand when I need to ventilate my patient. Clinically. Clear on this? When to ventilate my patient. Any doubts till now? When to ventilate? Okay. Now the next step that comes is, if I have to intubate these patients, is there something different that I want to do over here? What is my worry when I'm intubating? My first worry is the fact that I might release the hypoxic pulmonary vasoconstriction. Right? That's my one worry. What is my second worry?
Hypersensitive airway.
Hypersensitive airway. Okay, that's my second worry. Then it's already hypersensitive, it's already full. It's not a patient. See, what the hypersensitive airway and all during intubation. This all is something that comes in anesthesia. Where a person is coming from home, getting some kind of surgery done. Okay, and then you want to prevent that. He's already hypersensitive, already is in asthma exacerbation. You are intubating him not for that. He's already gone into hypersensitive. You are understanding what I am saying? Yes. So what all you said is purely anesthesia. What all you said is purely anesthesia. Where the person has come, nicely he's bronchodilated, he's come over there. At that time I want to ensure that I'm going to take him deep under anesthesia and intubate. This all comes where? When the patient is otherwise normal. This is when the patient is normal. This patient is not normal. This patient is already in the condition where he is in acute exacerbation or intubating for that reason. So will that hyperresponsiveness work in any way? Is that something in the back of our mind? It's not. It's not really on the back of our mind. You're understanding? It's gone. You go beyond that stage. That's why come out of anesthesia, you are now in critical care. You understand? Anesthesia may, yes, I want to take the patient deep under anesthesia. I want to ensure that the oxygen is good. There should be good paralysis. And then I want to give some puffs into the airway. All this nonsense now is for people who not in critical care. We are now in critical care. You understand? In critical care, it is 10 notches higher. 10 notches higher than what's happening over here. You are in that phase. Okay, in that phase. So sometimes it does happen that you have some anesthetist who comes over here when you're intubating your asthmatic patient and they speak all this crap. You must tell them, sir, it's beyond. It is beyond this. We are in the hyper-responsive area already. You got the point. So what do I do here? So what is my worry? What is my worry here? My worry here is the fact that I don't want to give large tidal volumes. That is my first worry. Why is that so? Because pehla air was not going inside. Now I am intubating and passing air inside. Already in an auto-PEEP condition where the pressure is very, very high. Are you understanding? You got the point what I'm saying? The lung is already dilated. And now I am full because inspiration I can do now. I can inspire. I can pass the positive pressure inside. Initially he was not able to pass because of bronchoconstriction and expiration was not happening. Now what happens? I am giving tidal volume now inside. And it is positive. So since I am going inside, the air can become bigger and bigger. This will cause what? This will cause more air trapping. And what is going to happen? The entire problem is intrathoracic pressure will go up. If intrathoracic pressure goes up, the blood pressure will drop. Intrathoracic pressure will go up, the blood pressure will drop. If you have an asthmatic patient where the blood pressure is not dropped after an intubation, then that is not asthma. Most likely that is not asthma only. Are you understanding? Because this asthmatic patient is at the level of his auto-PEEP. It is at that level. You are intubating that patient where the auto-PEEP is so high कि वो gas move नहीं कर पा रहा है. That means his pressure in his chest will be 20, 25, something like that. You understand? And at that moment, I am passing in air inside. So it is 90% chances that this patient will have hypotension. 90% chances this patient will have hypotension. Right? Clear on this till now? Not only that, if I pass air, what is the other thing that is occurring here? The other thing that is occurring over here is very interesting. You have a pulmonary circulation here. This pressure is going to constrict this further. So if I constrict my pulmonary circulation, the amount of RV to work become very, RV cannot pump that blood. No, RV is a low pressure pump, low pressure system. So you have now suddenly constricted everything. Now the RV is unable to pump that. You understand? So it goes into all kind of problems, cardiac problems, ventricular cardiac. You understand? So it goes to all type of problems. You got the point what I'm saying? So that is why your first tidal volume or the way you do this is very important to understand how to do this. So first, what is your preparation? Now that you've understood this, that there is probably going to be a hypotension. Now how will you think backwards? Now you've understood the pathophysiology that this patient, if he is real asthma, he is going to deteriorate. If you put the tube and he gets better, that is not asthma. That is vocal cord paralysis. That is something like some kind of mucus plugging. You understand? If you put a tube and he gets better and there's nothing happening with your ventilation, this is not asthma. By definition, if you put your tube inside and your peak pressures are 20, that is not asthma. If you put your tube inside, the peak pressures are 60, 50, that is asthma. You understand? Because the pathophysiology of asthma is pressure inside the lung increasing. So it's very awkward when you call me and sometimes and say, I put the tube so सब settle हो गया. अरे तो फिर asthma था ही नहीं है तुम. इसको bronchospasm कैसे बोल रहे हो तुम? How are you calling this as bronchospasm? Are you understanding? An exacerbation of asthma will relate with the peak pressure being on the higher side. You can't have the peak pressure going down. If the peak pressure goes down, it is something like mucus plug or it is something like vocal cord paralysis because you've just gone through the vocal cords and opened up that area. You're understanding? Clear on this? So that is so in short, my exacerbation is not going to come down. That is why I cannot create harm. When I'm putting my ventilator, I cannot create harm. I'm not going to put a ventilator and remove his exacerbation. वो नहीं होने वाला है. I'm putting a ventilator to keep him alive, so that there is time and keep it. You understand? For the lungs to get better. That concept you must understand, and that is the concept of permissive hypercapnia. So the entire concept of permissive hypercapnia is hallmarked on asthma and COPD. Why? Because the reason to do permissive hypercapnia is because I don't want to do anything to the blood gas. I don't want to do anything to improve oxygenation. What I want to do, I want to leave it the way it is and just keep him alive. So that's why I let the carbon dioxide go. I'm not bothered. This is called as permissive hypercapnia. You understand? I'm not bothered with it. And why? This is very important for you to understand. And that's why we started by saying it's a younger age group. And younger age group tolerate that carbon dioxide much better than elderly age group. You understand? So you might have a pH of 6.9 also. But if the BP is okay, patient is not having a problem, they are younger people. They may not have this problem. You got the point. Over a period of time, you realize that as he is getting better, the pH automatically improves. When it opens up, the carbon dioxide will exchange. You understand? And the QC will come down. When will it open up? Not because of a ventilation. It is open up when your drugs are going to work. This is failure of your drugs, no?
Yeah.
That's why you're putting this.
Yeah.
So you have to give him time for those drugs to work. You're understanding? This concept should be in your mind. It's very essential. Very, very essential that this concept is in your mind. Unfortunately, what happens is, I'll tell you what exactly happens. You are on the ventilator, you are about to intubate, you intubate and the first thing you see is oxygen going down. You take the ambu bag and you start ambu bagging. Oxygen is going to go down. Why is it going to go down? You tell me, Yogita.
Hypoxic pulmonary reservoir
Is getting released. Since it's getting released, deoxygenated blood is coming down. So naturally the saturation will come from 90 to 75 and 76. That is going to occur. That is going to occur. You understand? But then you reacting suddenly, or saturation drop, ambu bag le lo. Will create what? Will create that whole amount of 500 plus cc. Your ambu bag is 1500 cc. You put that ambu bag inside, you will give so much of air inside which will worsen whatever you are doing. It will worsen whatever you are doing. You understand? So it is completely wrong to do something like that, and that is why clinically you must understand the patho behind it. Nobody dies of hypoxia, remember this. It takes time to die of hypoxia. So give some time. It will get better. Stand over there. Not that give some time is that leave and go. No, I'll stand there. I'll see what's happening and then take that call. You understand? But never in Abu bag. Abu bag becomes a murder weapon when you're looking at asthma and COPD. You never do this. This is the only condition when you're going for a transport that you put the patient on a ventilator. This is the only condition that if you have a patient of asthma and or COPD, if you want to send them for a CT scan, I will put them on a ventilator because I don't want to use my Abu bag when I don't know how much I'm delivering. You understand? I don't want to use that. I want to give finite delivery. So if you're transporting a patient of severe asthma or COPD to the CT scanner, you have to use a ventilator with controlled delivery of tidal volume. Clear on this? Paralyzed patient. This is one of the cases where you paralyze the patient and take them down. Okay, I want the patient to be paralyzed, not fighting the ventilator, it will become problematic. So, others paralyzed patients. So here you're going to paralyze, so it's a big change, right? So again, now to answer this question, what is your preparation? What will you keep? What drugs you want to keep ready? And how? I need to keep what? Noradrenaline. Adrenaline. Which is the best beta inhibitor you have?
Adrenaline, yes, right.
You are thinking blood pressure, but I want even some proper validation to occur.
Yes.
Isn't it? So my drug that I'll keep ready is adrenaline. So how much will I keep and how do I do this? So the answer is to actually start it at 10 microgram per minute. That's approximately 1 microgram per minute. That's around 50 microgram an hour. You understand what I'm saying? Somewhere around 50. So what do you do in this case? How do you do this? So why am I saying to give, and what is actually the dose of how do you give adrenaline? Otherwise, if the patient has got sudden bronchospasm, how do you give adrenaline? No, it's given IM. If you have anaphylaxis, what is the drug of choice? Adrenaline, 0.5 milligrams IM. This doesn't work in ICU because IM means what is going to happen? The absorption is not immediate. It will take a long time before it actually acts. And normally, what is the dose of in anaphylaxis? The dose is 0.5 milligrams given every 15 to 20 minutes. This is the dose. The dose for anaphylaxis, or for that matter, in hyperresponsiveness of airways, it is 0.5 milligrams of IM epinephrine. Okay, given every 15 to 20 minutes. We don't know how this patient is going to actually react. You might see 0.5. Okay, it's 10 minutes now. Patient has not improved. You might give another 0.5. This will cause dose accumulation, and suddenly patients will go haywire. What is also the problem with IM? Once it goes inside, I can't take it out. Once it goes inside, I can't take it out. It will take a long time before. So if this patient, you give 0.5 IM and then sometime later there is ST segments depressed because of the tachycardia and ischemia that's occurring in the heart, because heart is now contracting at 180 and 190 pulse rate. Okay, you cannot take it out. You're stuck. That is why you need to use IV. That is why you need to use IV. So what will you keep ready? You will keep 8 milligrams in 50 cc. Is what the usual dilution that we are using. Keep that on. Keep it at 15 ml per hour. Keep it at 15 ml. It's going to take some time, and then titrate it. And then titrate to get it back to 3 or 4 ml per hour. Okay, why I can titrate? Because if I stop, the effect will come down within some seconds. You understand? I'm starting it at a higher dose because I don't want the blood pressure to drop. Okay, so I will start my patient on adrenaline. I will start. You understand? I will start it. Okay, I'll keep it on. If I keep it out at 10 ml per hour, it is going per hour. It's not in that instant. 10 ml per hour it is going. 15 ml per hour it is going. You understand what I'm saying? So you started at 10 ml per hour. By any chance you see the tachycardia happening, or there is no requirement, you can just reduce it. Clear? So what drug you will first keep ready? You cannot at that moment say keep push dose ready. No. You in these cases the big difference is you keep the adrenaline running. Keep it on because the BP will drop. We know that others is not asthma. BP has to drop. That's the reason that the patient is like this. So the one difference you noticed is what? I will keep what ready? So in your intubation when I talked about, I was asking you what you will do. You said almost the same thing. It's not the same thing. What I did differently? I kept adrenaline on flow. Okay. This also is an addition. What I do different is keep an IV fluid running fast. Because we know these are young patients. Their hearts are otherwise normal. They are young people. Their hearts are otherwise normal. Giving that extra fluid is not going to harm. You understand? So keep that fluid fast. So the next thing I'm going to keep is a IV fluid on a pressure bag running fast. So this is the second difference, Yogita.
Yes, sir.
What is the first difference?
And
Second difference is?
I
Then the third difference. I will want to keep the largest endotracheal tube that I have. The largest endotracheal tube that I have. So I will give anywhere upwards of 8.5. Why?
Resistance.
8 to 1 is the resistance. One is that we want the resistance to be minimum. Second, secretions. Bronchoscopy. What is our pathophysiology? Mucus plugging, hyperreactive airways and inflammation. Mucus plugging is a very important part, causes collapse of the lung and things like that. Right? So if tomorrow, day after, I want to do bronchoscopy, I can't do it through a 7-number tube. It will not go, the scope doesn't go. Your scope doesn't go. So you require the largest tube. Ideally 8.5, 9, 9.5. This is the kind of size I will use over here. Because I have two things in my mind. One is the resistance of the airway, and the second thing is I want to do a bronchoscopy. I might have to do a bronchoscopy sometime on the other. You understand? Clear on this? So I want the largest possible tube over here. Clear on this? Any doubts still now on intubation? Okay. What about the drugs? Won't that make a big difference? What drug will you use? What drug will you use? Otherwise you're using midazolam and fortrin, isn't it? You're using etomidate. What will you use here? I will want to use a drug that will not drop the blood pressure and at the same time bronchodilate the airway. So I will want to use maybe a combination of two drugs, ketamine and propofol. I will need to use a combination of two drugs because propofol is a strong bronchodilator. Ketamine is a strong bronchodilator. So I will use both those together and my drug protocol will change to ketamine plus propofol. Because I don't want the patient to be light, at the same time I want the patient to be deep under anesthesia. So I will use both ketamine and propofol. I will take the benefit of ketamine's bronchodilator and I will take the benefits of propofol's bronchodilator and quick, the way it goes inside quick. You understand? So ketamine followed by propofol. This is what I would be doing. And that is the reason that the adrenaline should be on flow also. You understand? You should not get panicked, propofol, the BP drop ho gaya. No, you should not get panicked. BP is going to drop. Why is it going to drop? Because once he goes from the sympathetic overactivity to an anesthetic state, the blood pressure is going to crash from 190, 180 to 100. That is going to occur. Not because of intubation, just because you have removed the sympathetics. Till now the sympathetics are on. That's why you are additionally putting that small dose adrenaline because it is going to supersede that sympathetic drive that is going down. Sympathetic, you understand? So there's a whole lot of difference that we did. Whole lot of difference that we did till now. Okay. Now the first set, now we come to the settings. You understood this much till now?
Yeah.
You understood? So ambu bag will be dur. It will not be even near me. I don't want to even by mistake take the ambu bag in my hand. You understand? So when I want to be ensuring that my tidal volume is well delivered. And so what will be my tidal volume in such cases? Now we go back to the settings of the ventilator. What will be my tidal volume? So the tidal volumes essentially should be large here. It cannot be 4 and 5. Why is that so? You in the middle you did say I go to 4 and 5 and all.
But we don't want to give large.
I don't want to give large. But why, if I give 4, what is going to happen? If I give 4 and 5, what is going to happen? Tell me that. How? Why? You're right, but why?
Dead space is 4 ml per kg tidal volume also written है तो dead space में गए तो 115 minutes.
So we are giving so many patients 4 ml per kilogram. कुछ हो रहा है क्या? So there are so many patients giving 4 ml per kilogram.
Minute ventilation won't be achieved unless tidal volume with RR is to be less. Then CO2 ventilation.
And yeah, if you increase the ventilation, other people increase, no?
But that much.
The answer is asthmatic patients have got a larger dead space. That's the answer. They've got a larger dead space, isn't it? What is happening? What is dead space? Dead space is that part of the gas that does not participate in gas exchange. This is exactly what we are discussing, no? There's a huge amount of gas that is not taking part in gas exchange. Are you understanding? There's a huge amount of gas that is not taking part in gas exchange. So you understand what I'm saying? So if your dead space in normal individuals is 2.22 ml per kilogram, here the dead space may be 3, maybe 3.5, maybe 4. You don't know. So you don't go down on the tidal volume because here my plateau pressures are not that important here. That's ARDS. This is asthma. Are you understanding? Any doubts here? Because if I go down on my tidal volume, I will be ventilating what? The dead space. If I go to 4 ml per kilogram, your effective tidal volume is going to be only ventilating dead space. You understand? Probably that's going to happen. What is going to happen because of that? Your carbon dioxide will just keep on going up. There is like no ventilation. You understand? There is like no ventilation at all. It will just keep on going up. So if I want to get to permissive 80, it will become 150 and 180. You know, this is one mistake that people do because that 6 and 4 is ingrained so much in your mind about this ARDS net protocol that this is what we should do, this is what we should do, that you end up looking at plateau, you end up looking at at tidal volumes. You got the point, huh? And this is the issue that occurs in such cases. Remember this, the peak pressure, the pressure that you see on the ventilator is going to be a combination of compliance and airway resistance. So it's going to be classically on the higher side. समझ में आ रहा है? So
but in COPD patients, we try to give low tidal volume because to avoid dynamic.
Volume is not equal to pressure. What we are talking about, dynamic hyperinflation is related to pressure. Auto PEEP is what? Pressure. It's not volume. How much volume of that is causing an auto PEEP is what you have to find out. You understand what I'm saying? Huh? It is not linear. It's not completely linear. More often what happens, if you don't give that volume, you want the airway to be stented, right? If it's stented open, more amount of oxygen or carbon dioxide will get exchanged. If it stents open, if it by any chance stents open, you will have more exchange that is occurring. So if you give a very small tidal volume, the stent function of it, there are many functions of tidal volume. One of the problems also, you're right, that if you put volume too much, the pressure might increase. It might increase. But it might decrease also. If it stents open, the pressure will come down. Are you understanding? What happens after giving a tidal volume, you have to see. Are you understanding? You are understanding the point, Yogita?
So, but we will start with 6 to 8 ml or we will give 8 to
You can start 8 ml. What happens with that, you have to find out. What happens with that, you have to find out. You understand what I'm saying, na? What happens usually, no? What happens what might be happening logically is when you are giving 8 ml of tidal volumes, air was not moving at all. First, initially, air was not moving at all. Now, air suddenly starts moving. When air suddenly starts moving, two things might occur. One, the pressure in the alveolus might go very high, and two, what can occur? The pressure might go low, because what can occur? The moment you put the air, the airway is tented open. When airway is tented open, what is going to happen in expiration? More amount of air is going to come outside, so it might get more better. So you don't know what is going to happen. You don't know what is going to happen when you are going to give a tidal volume. More often than not, it will stent open the airways. More often than not, it will get the pressures to go low. More often than not, it will cause the auto PEEP to come down. That's why the tidal volume is important. Are you understanding? समझ में आ रहा है? What happens? It might cause the other effect, but that is what you are there for, no? You are there to understand that. It is not pressure. It is volume. Clear on this? Huh? So I will start at what tidal volume? And now, just to make you all understand, tomorrow when you actually go to the ASV mode that is there, the adaptive support ventilation mode on Hamilton, what does that do? You know, that actually looks at the entire work of breathing and then adjusts the pressures and volumes. It does everything. It adjusts the pressures, adjusts the volumes. So if that patient gets bronchoconstricted, any of your patients who are on ventilator and patient is on ASV mode, adaptive support ventilation, and the patient gets bronchoconstricted, the ventilator increases the tidal volume. See it next time. Go and see it next time. It will increase the tidal volume because that's what it's supposed to do in asthma. That's what it's supposed to do in bronchospasm. समझ में आ रहा है? Huh? Clear on this? So you understand what I'm saying just now? On the machine, there is an adaptive support ventilation which is not under your control. ASV. The machine decides what tidal volume to give, what RR to give based on work of breathing, based on a lot of things including RC, EXP, which is the time constant, respiratory compliance and time constant. Based on that, it takes a call what should be the tidal volumes. That machine, if there's bronchoconstriction, will actually cause the tidal volumes to go higher. Clear on this? That means you require higher tidal volume. Are you clear on the tidal volume now? Are you clear on the tidal volume here? Clear? Okay. Any doubts on tidal volume? RR, what about RR? The RR has to be as low as possible. Okay, I can't have a minute ventilation of 2 ml or 2 liters. I have to have a minute ventilation 6 to 8 at least. Okay, that's regular ventilation. So I will need to actually reduce my RR. So now imagine if you reduce your RR and reduce your tidal volume, what is going to happen? It will not be there only. You understand? We will be ventilating what? The dead space. You get the point? Huh? So if you are tired, you take the example of RR of 10 and you take the example of say 400, which is actually high, 6 ml per kilogram of pakada, you know, and the patient is say 50 kilos, it should be 300, isn't it? Huh? So 50 kilos, so what are you making? Can you give a bed ventilation of 3 liters to any patient? You understand? All the more reason for you to understand logically that the tidal volume should be on the समझ में आ रहा है?
बट हमने सर इनिशियली तो बोला कि लो टाइडल वॉल्यूम
कौन बोला?
नहीं बोला
मैंने नहीं बोला किसने बोला वो? इसलिए मैं लिख कर रखा ऊपर हाँ?
अभी मतलब जब ले रहे थे हम कि व्हाट आर द मतलब डिफरेंस ड्यूरिंग वेंटिलेशन मतलब ड्यूरिंग इंट्यूबेशन we have to keep low tidal volume ना because already air उधर है वापस ज़्यादा
air है air is causing what? Pressure. We are saying that the air is causing an increase in pressure, but what are we giving here? We are giving volume here. We are giving air, but how much the pressure is increasing we don't know.
have to find out that
But also what we are doing, we are also balancing the RR. The RR is 10. If I keep my RR 10, we have to do that because expiration is passive. You cannot change that because if the RR you have kept high, your expiration time will come down. So I need to give RR of 10 or 12. I can't give RR of 18 and 20. I can't do this. This I can't do. Huh? My RR is fixed at 10, 12 or something. My RR is fixed at 10, 12 or something. Now if I give low tidal volume, what is going to happen? Minute dead space. You have to balance oxygen, you have to balance carbon dioxide, you have to balance pressure. So in that balance, it seems that if you give a higher tidal volume and a lower RR, you will help the pressures to get better, the auto peep to get better. Are you understanding this? So there's a big difference when I'm ventilating an asthmatic patient versus another patient. Now you understood? It's not the same. That's why I kept asking you, is it the same? Is it the same? You kept saying it's the same. It's not the same at all. It's completely different, isn't it? Clear on this now? Am I clear till now?
Yes,
So
sir.
the RR will be low. So my first RR will be what? Say maybe 12. Maybe 12. Okay, this is what I'm going to do. I'll keep the RR at 12. Okay, and I'll keep the tidal volume say at maybe 550, something like that. Okay, 550 or 500 or something like that, 500 something like that, 480, 500, 480, 500. This is what my tidal volume will be. What will be my FiO2? My FiO2 will be such that I'll keep it minimum just to keep my saturation as 88. I don't want it to go higher than that. There's no point. We understood why. We don't want it to be higher than that. So don't, unlike normal ventilation where we start at 100%, here we will not be starting at 100%. We will be starting at a lower amount. Understand? We will be starting at a lower amount only. If the patient saturation is 50, you have actually missed the bus, that's a different situation. If the saturation is 50 and she is cyanotic and all, वो अलग बात होती है. But that is wrong practice, no? If you are intubating the patient when the patient is cyanotic, what have you done all this time? Are you understanding? You can't be intubating a patient like that. You are intubating a patient much in advance. You got the point? Much in advance. Clear on this? Clear on this? So the what all has changed compared to normal intubation? Tidal volume has changed. Preparation, what? Right from preparation, what all has changed?
Adrenaline.
Well, let's do one by one. Ankita, adrenaline, Sakib,
IV
IV fluids, very good. Fast IV fluids, that's the answer.
ET tube.
Large size ET tube.
and
Ketamine and propofol changing paralytic agents. Okay, then
last tidal volume low RR.
last time volume and raw RR. Okay, so many things have changed. Anything more?
Lower FiO2.
Low FiO2. Low FiO2. So these are the huge changes. I mean, this is completely different from what we normally do. Normally we give low tidal volume. Normally we give high FiO2. Normally keep the RR tense or minute ventilation. Normally we ensure that they, this completely different, isn't it? It's completely different. Okay, that's how your intubation is going to be. That's very, very important. Right? Now, when you intubate these patients, you have understood these tidal volumes that you're going to give. Let's go and understand how these waveforms look. Okay, so this is a time when you actually need to be certain. You need to be certain about your pressures. Okay, so one question that we're going to look at is what? What are the various maneuvers you like to do? Once you've intubated a patient, what are the various maneuvers you want to do? So this is the time you have to do the maneuvers. You can't not do the maneuvers. समझ में आ रहा है? Huh? This is the time you want to do the maneuvers. You understand what I'm saying? So what are the maneuvers you're looking at? Let's go back to our ventilator first. Okay, what are the maneuvers I'm going to look at? So what you're seeing here is a volume control mode of ventilation because there's variable pressure. There is a flow and there is a tidal volume. The flow is stopped over here, means inspiration is stopped over here. This inspiratory phase is going on. Inspiratory phase is going on. So if I look at it very carefully, what is what? This is pressure, flow, and this is volume. This is the time. So pressure versus time, flow versus time, and volume or time. This is TLC when you say trigger limit cycle. Triggered. This is volume control because it's limited by volume and cycled by time. Right, and the pressure is variable. So TLC variable. It's TLC we have now discussed what this is. This is probably a volume kind of limited mode. Okay, what you see over here is pressure versus time. And what you see over here is inspiration. This is your expiration. Okay, this is where the inspiratory phase is ending. This is where the inspiratory phase is ending. The inspiratory phase is ending. However, the inspiration is stopped right over here. Inspiration is stopped right over here. Now, what is happening over here? There is a inspiratory pause. What is happening over there is an inspiratory pause. And what is happening in the inspiratory pause? The airway resistance is cutting off in the inspiratory pause because there is no flow of gas. There is no flow of gas. So there is no flow of gas. Since there is no flow of gas, the airway resistance has become zero. We are assuming that the airway has become zero. So whatever we are seeing ahead is lung compliance, plateau pressure. The airway has gone off. So when I am getting off the flow, what am I wanting to see? If you remember the diagram I showed you last time, this is the diagram. I want to cut off the pressure that is coming from your elastic resistance. Right? And this is what elastic airway resistance and elastic resistance. I want to look at the elastic resistance, which is the opposite of my compliance. And this I am going to look at my understanding plateau pressure. This is airway pressure. And this airway pressure is dependent on the flow.
Yes, sir.
I am cutting off this flow. Since I am cutting off this flow, the pressure that now my airway is seeing is the pressure over here, which is the plateau pressure. Clear on this? So what I am seeing now is understood the diagram?
Yes, sir.
So what you are seeing is the plateau pressure. And for that I need to do an inspiratory hold. So this means to say, this resistance that I am getting from here to here is the airway resistance.
Yes, sir.
Clear? This was the airway resistance, right? Here two parts of that plateau pressure, two parts of this pressure. One part of the pressure was airway, second part of the pressure was plateau, right? The plateau was the lung, airway is the airway, right? When I remove the airway out, what I see is the plateau, is the lung. Okay, that means to say this part is my airway, and that is why if the patient is in bronchospasm and it is purely related to airway, that part will go up, peak pressures will go up. You understand? That's why the peak pressures will go up because this part is your airway. You are understanding the genesis of high peak pressure?
Yes, sir.
You understand genesis? High peak pressure? This is your inspiration, right? This is where your expiration is. So I understood peak pressure now. Why peak pressure goes up? Because that is your airway. Clear? So understand this very well, okay? So volume control versus. Okay. Now let's go to bronchospasm. Okay. So if you see very clearly what is happening over here from the earlier graph, what has happened over here? The pressure has gone up here.
Gone up. Yes,
this line has increased. See this?
Yes, sir.
This line has increased. So that is your airway resistance. When I do an inspiratory hold for a period of 2 seconds in a patient who is not triggering the ventilator, I can then notice my plateau pressure. I cannot do it when the person is actually breathing. Because if you will say I'll put an inspiratory pause has to be for 2 seconds. More than 2 seconds. The inspiratory pause cannot be for less than 2 seconds. Why? You cannot just say I'm going to do plateau pressure, I'll press inspiratory hold and see my plateau. It doesn't work like that. Because why? Why? Because you have not just one alveoli of this size.
Different
You
time
may have an
constant.
alveoli which is small. You may have another alveoli which is large. and at the end of the day I am noticing my pressure at the airway here, which all coming and joining together, and I am noting my pressure over here. I am noting my pressure right here. समझ में आ रहा है ना? Where my main airway is, मेरा pressure ये जो measure हो रहा है, this is measuring where? This is measuring here, not down here. This is measuring here. You're understanding? So if I give a plateau, if I give a hold of 2 seconds approximately, what is known, more than 2 seconds, is known that all this gas constants, the time was different, na? Time constant is the amount taken to, amount of time required to deflate the lung, right? So the time was different over here. We are assuming that many parts of the lung are now actually deflated, and that's why what we are seeing is that pressure. Okay, if you just put 1 second, you might not see all the pressures. If you just put 1 second, that's why you need more than 2 seconds. So if you have a breath cycle of 6 seconds, okay, and you have 2 seconds of inspiration and 4 seconds of expiration, I can't have inspiratory pause like this. My inspiratory pause will be 2 seconds, no? You know, that means if I want to give 2 seconds of inspiratory pause, what will I have to do? I'll have to make my inspiratory, because 10 respiratory rates, not now. 10 respiratory rate means 6 breath take cycle hai.
Yes, sir.
And if I keep 1:4, like 1:3, let's take 1.5:4 आएगा ये. Approximately 4.5 आएगा ना. This will be my 6 seconds का. If which inspiratory phase will be 1.5 seconds, expiratory phase will be 4.5 seconds. If I want to give inspiratory pause of 2 seconds, my phase is only for 1.5. My phase only 1.5. I can't keep an inspiratory pause, but there's an inspiratory pause button on the ventilator. Okay, inspiratory pause. I can set an inspiratory pause. I can't set it in such cases. You understand? So since I can't set it, I need the patient to be passively breathing so that I can do that maneuver. And that maneuver involves pressing inspiratory hold for a period of 2+ seconds. So many times you often see people coming like inspiratory hold देख के मैंने ये है उसका plateau pressure. It's not like that. You have to hold it, wait for the patient. The patient should not breathe, and then you see the inspiratory plateau pressure. Clear on this? Clear? All right. So what is happening in bronchospasm? If you look at it, what is happening here? See that? What are the various changes you are seeing here? What are the various things you are seeing?
Increase in peak pressure.
Tell me the changes. Huh?
Length of the volume was increased.
It's almost done. Yeah, we are at the end of it almost. You go continue. Huh? So what are we seeing here? So what are the few things you can see here? You can see that the peak pressures have gone up. It's gone up compared to what it was earlier. We see the plateau has come down. This is the time I want to do my inspiratory hold to figure out what is happening. What other thing you can see? You can see that the expiratory flow is not reaching the baseline. It is not reaching the baseline at all. If you see it very clearly, it is not reaching the baseline. It is taking off from down itself. You can see it now. It has to go to the baseline. It has to come like this. Is it going like this? It's not doing that. What is happening is the flow is reaching till here and then taking off from here compared to the earlier one. You want to see the earlier one to understand this? Huh? So what is happening in the earlier one? See? What's happening here?
Touching the baseline.
The flow is actually reaching the end, and then there's a flat line, and then it is starting up again. Clear on this? समझ में आया तुम लोगों को? हाँ? Now compared to this, look at what is happening here. It's not reaching the baseline, right? What else you can see the difference? You can see the difference, na? Look at the peak expiratory flow here. The peak expiratory flow. Look at it. Okay. Look at the peak expiratory. This is the expiratory flow. Now, because it's an obstruction of the airway and it is passive, the expiratory flow is reduced. So look at it, what is happening? Huh? Because this obstruction an obstruction is passive, what is happening over here? The expiratory flow is actually very low. It is passive, but it's not active. So flow has become reduced because हवा अगर कमी जा रहा है तो flow कम हो जाएगा ना मेरा. समझ में आ रहा है? Flow ही कम होने वाला है. That is why that will be a target of your bronchodilation. That will be a target for your bronchodilation. So if you are a patient on the ventilator and you have set the ventilator and now you have done the first initial intubation ventilation, you quickly check the plateau, quickly note the peak pressure, quickly look at the flow, quickly look at the autopeak. Okay, because when this actually improves, that means it becomes more deeper, means the peak expiratory flow is increasing. This means to say that your airways are opening up. Clear on this? Am I clear on this? Huh? So what are the things you're noticing over here? You're noticing that there's a flow is not reaching the baseline. You're noticing that the peak expiratory flow is on the lower side. You're noticing that the peak pressure is on the higher side. Right? Clear on this? So that's why you see the P peak over here being 55. This is different from the P mean. P mean is the mean airway pressure in this entire area. P mean. You see P mean there? P mean. In some it is called PAW. In some it will be called different names. You must understand what it is. The highest pressure you see is the peak pressure. The highest pressure. If you see anything lower than that, it would be the airway pressure, which is the mean airway pressure in the airway. So this all this black, if you multiply together or add them all together, you get this. Clear? Huh? If you add them, that's the pressure you get. Clear on this? Clear? Huh? So that's about bronchoscopy. So you see very carefully how it looks. Okay? See that? Registered in your mind? Register this very well? Okay. So let's go ahead. Okay.
So why we are giving that pause?
What?
Pause.
The pause here. This is for demonstration. If inspiratory pause करें तो ये से दिखेगा ये. It's for demonstration purposes. It will never be, that pause will never be seen. I will not put a pause. I cannot put a pause. I just explained to you all. I can put a pause. Clear on this? So see the difference between both? I can see the difference between normal and abnormal. Huh? Clear on this? See? Can see the difference, right?
Yes, sir.
Clear difference. See the airway resistance is very different from the normal. So this is when a person was normal and then he became abnormal. Okay, the resistance just increased. If you look at the tidal volume, it means 623, and frequency is 12. What is the difference between both of them? Is only airway resistance. Your tidal volume is 623. Your this is 1.7. Your compliance is remained at 30. Everything is the same. What has only changed? The only thing that has changed is the airway resistance. You can actually even see that it actually monitors this airway resistance also. If you were to actually go into one of the calculations here and open it up and look at the calculations that are there, you will get airway resistance also. Okay, which we discussed 6 to 10 is normal, more than 10 is abnormal. You will see that. 6 is normal. You will see 12, 15, 20, 25, you will see the resistance. Clear? Huh?
Yes, sir.
Now, compared to this, in COPD there is something else that occurs. So what I must notice in this case, if I have to treat this patient, it should become like this. There, the peak flow should get better. Right? Now in COPD something else occurs. What happens in COPD is something called as air hunger. In COPD what comes as something occurs is air hunger. What is air hunger? Air hunger is what happens to a COPD patient. A COPD patient is unable to get that air. All these patients have air hunger, but COPD has excessive air hunger. So they want to take it like that. Because they don't get the flow that they require. That's why if you see most of them have positive breathing. They breathe like this. Why they breathe like this? Because they're not getting that air. They want the flow. It's not the volume, it's the flow. They want the flow. And to improve the flow, what do? They purse their lips so that the flow increases. Okay, they want to increase the flow. So that's why they have something called as air hunger. Okay, and that makes it very difficult for them to trigger the ventilator, very difficult for them to actually get that flow if you have a volume control mode of ventilation. Because what is volume control mode of ventilation? What is the flow in volume control mode? Is it constant or is it decelerating?
Square.
Constant flow. So if you set a flow for this patient that is constant and he requires more flow, he will show air hunger. Are you understanding? He will show air hunger. So this is one of the change in the tidal volume settings between COPD and asthma. You got the point? The flows have to be quite high. You got the point? The flows have to be quite high. So you may have to increase the flows. That means to say to increase the flows, what I can do? I can reduce my inspiration to the minimum that I can if it's a volume control mode, because if I reduce my inspiration to the minimum possible time, my flow will increase. That's the difference you have with COPD and asthma. And how does that look? How do you think that will look on the machine? How do you think that will look on the machine? How do you think? Now this is let's assume that this is what is normal. How will it look on the machine?
Sorry. Flow time का वो flow का height
Flow का?
एम्पलीट्यूड बढ़ जाएगा और
and time.
No, tell me what is. So you're saying the flow volume curve will change, right?
Flow time.
Flow time curve will
Time
change.
will
Anybody else? Anybody else?
Peak inspiratory flow.
What will change? The flow is constant, no? The flow is constant. So what is going to change here? The pressures will change. No, the flow is constant. So the flow might not alter as much as the pressure. You understand? The volume, what is going to change? The pressure. Patient is taking air like this inside. Flow constant है, उसको मिल नहीं रहा है वो flow. So pressure change होएगा ना. So what will happen? What will happen if you look at it practically? If this is my pressure times scalar, okay, pressure time. This is my pressure. This is my scalar. What did we decide? We decided it goes like that, right? हमने ऐसा बोला ना.
Yes,
What
sir.
will happen in this case? It will go up and there will be a scallop. There will be a scallop of the wave because he's drawing in that. You got the point? Huh? So that's why there will be a scallop in the wave, which is basically called as air hunger. So you should be seeing it on the ventilator and saying air hunger. That means any patient in your ICU, that waveform you should know about air hunger. Okay, because you never know this patient might become metabolic acidosis. That acidosis will cause air hunger. That air hunger you should recognize. Okay, so how does it look on real time? Let's put that. Can you see that? What's occurring? See that?
yes sir.
See that? See? There's an air hunger up. See that? It's not getting adequate. Pressure तो एक ही था. Suddenly pressure तो एक ही था. लेकिन उसको और हवा चाहिए. तो वापस reason rather than actually getting more air, you should get more air, no? But this is pressure. It reflects by showing the pressure going downwards. The flow doesn't change because flow is constant. Otherwise, what you should have seen? The flow going up. What you should have seen? The flow going up. But the flow is not going up. Flow is constant. You understand? Ventilator can't give more. Ventilator is not able to give more because हमने flow constant करके रखा हुआ है. But what is happening? Patient wants more. And so what is happening to the pressure? The pressure is galloping out. You understanding this? It's very important that you understand this. Okay. So again you can see it once more. See, patient is breathing, but this is scallop coming. Trigger the ventilator came down. Okay, fair enough, fair enough, fair enough. I'm breathing, I'm breathing, I'm breathing. I will get taking and one more breath is coming. It's like one more breath coming. It's not one more breath. Why it's not one more breath? Because there is no extra breath coming here. You might think that this is an extra breath. No. तुम बोलेंगे कि एक breath हो गया, एक second breath आ गया. Second breath नहीं है. It is the same breath. It is the same breath because if it was a new breath, what would happen? Flow would come in. Let's go down. Is the flow coming in? No. You understand? Since no flow is coming down, this is the same breath. Unfortunately, the patient has air hunger, so the pressures are dropping. This is called as COPD air hunger. Okay, this is called as air hunger. Clear on this? Any doubts here? Any doubts on understanding this? So this can occur in any patient, okay? This can occur in any patient. It's not necessary that it will occur only in COPD. It can occur in any patient that you have, this kind of air hunger. Clear? Huh? Clear on this air hunger? This is an intubated mechanical ventilation. It will not be a non-invasive. You can see it only in intubated. What will be the strategy here? The strategy here would be two. Okay, what was the strategy for auto PEEP? We will go to the strategies. We go back to strategies. Okay, so if I go back to auto PEEP, what would be my strategy here? What will I want to do? What will I want to see? What happens?
Expiration.
Sorry?
Increase expiration.
So one of the things is I will increase the expiration. That means I will reduce my inspiration.
Expiration.
So what can I do? So you said I will increase my IE ratio. I'll make it from 1:2 to 1:4. Let's take it like that. Then decrease RR. Then you want to give PEEP.
Extensive PEEP.
We didn't come to PEEP yet. We'll come to PEEP. Huh? You want to increase PEEP. You want to increase PEEP. For so let's come to this concept properly. Okay, I'll come to this concept right now. Let's not. So she did say increase PEEP. What is going to happen if you increase PEEP? It will overdistend, no? So you are confused with the fact that I want to negate my dynamic PEEP with some amount of PEEP. Is it what you are trying to negate? That comes when you want to trigger the ventilator. Let me explain to this once more. Okay, let me explain to this once more. Okay.
Trigger limit.
Okay. With the dust of the PEEP is what you have learnt, na? Every time. That's why we are talking this again and again. Give some PEEP, give some PEEP. Huh? Let me explain this once more to you. You have the airway. You have the alveolus. What has happened in COPD asthma? You are having a PEEP that is there, that is over here, which is already there. He's got a PEEP of say 6. Let me take the PEEP of 6. Okay. This means to say, let's make this 10. Let's take normally first. 6. Let's take it as 4. Normally what is occurring? You generate -4 and air rushes inside. This is normal. Air rushes inside because you generate, all of us are generating a -4 pleural pressure negatively, and that's why air is coming inside. Now let's take the other patient. What we know, we discussed all this, that the PEEP inside the airway is increasing, right? It's called auto PEEP. That auto PEEP is say 12. Now what the patient needs to do? The patient needs to
Generate
overcome 12, generate -12, then only air will go inside. But this is for a trigger. This is for a patient who wants to trigger the ventilator. We are not even dealing with trigger. Are we weaning this patient? You understand? I'm not weaning this patient. I'm not concerned with triggering this ventilator. No. You understand what I'm saying? So to get off my auto PEEP, does it make any sense to add PEEP?
No.
You understood what I'm saying? You got the point?
Yes, sir.
That auto PEEP and all comes when? When the patient is triggering, no? It is only when an active patient is there. Otherwise, there is no point of adding that auto PEEP by negating. So I will not put that strategy here. I will not put that strategy over here. I can put that strategy when I'm thinking of the weaning time, when I'm weaning off the ventilator, but not at the time that when I'm going to combat this, when the patient is bad, so sick and all this. I'm going to look at all these things. So in this, he said one is I ratio, second is RR, third thing, how do you reduce this? Yeah, come on.
Pressure.
Sorry, reduce tidal volume ना. If you cannot do anything, you reduce tidal volume. कुछ नहीं हो रहा है, इतना ऑटो PEEP डेवलप हो रहा है कि पेशेंट का हाइपोटेंशन हो रहा है, ये हो रहा है, वो हो रहा है. What do you reduce? And this is very important for you to understand, because what sometimes does occur is you have put the patient on the ventilator and suddenly patient arrests. You put the patient on the ventilator, suddenly patient arrests. What has happened? What has happened? Auto PEEP has developed. Auto PEEP has developed in such an extent that the venous return is completely stopped. And venous return stops and the patient is arrested. What do you do in such cases? Disconnect the ventilator and press the chest wall. Disconnect the ventilator and press the chest wall. Disconnect the ventilator and press the chest wall. Classically, you will hear a sound. Sound आएगा. That is the air rushing out of the gas from inside. You will hear a real like a train sound. You will hear. What is what I'm saying? You will hear a sound of a train. और तो ऐसा train का sound आएगा. Sound आएगा. That means the air is just rushing out. You understanding what we're doing? You understanding? So if you put the patient on the ventilator, patient arrests. First thing in your mind, disconnect, press the chest wall. Because what have you created in an asthmatic patient? You have created so much of auto PEEP that the venous return has become 0 and the patient is arrested. Clear? So I will do all these maneuvers, only when I have a problem now. I will not do it otherwise. I will go auto flow हो रहा है, patient otherwise okay, BP normal है, pulse normal है, तो कुछ मत करो. You understand? Patient को तुम्हारा BP 140 था, 110 हो गया, 120 हो गया, there is something here. Better to do something here. That auto flow, whether it will create a problem, you must understand. हर auto flow को correct करने की कोशिश मत करो, because everything that you try to correct will have its after effect of raising carbon dioxide. Will have its effect of raising. You do this, or you change the tidal volume, it will raise the carbon dioxide. Clear on this? Raise the carbon dioxide. So you must be understanding why am I doing it. I am not there to treat that graph. I am there to treat the patient. So if that auto flow restriction is causing an extent that the auto PEEP is increasing relating to a hemodynamic embarrassment, then I want to take care of the flow. You understand what I'm saying? And the way I can correct this by increasing your I ratio, reducing my RR, reducing my tidal volume, and accelerating the bronchodilator. Increasing the bronchodilator, isn't it? If I increase my bronchodilator, what is going to happen? the expiration will improve, this will reach its baseline. This will reach its baseline. समझ में आ रहा है? So don't try to treat the ventilator. Try to treat the patient. So when you try to treat the patient, you will also use the ventilator as a feedback system. You know, if you try to treat the patient giving bronchodilator and all these things, and you'll find that the waveform is getting better and better, you know, I have not changed the ventilator. I have just bronchodilated. This means it's working. My bronchodilator is working. My flow has started reaching the baseline. My peak flow has increased. If you treat the ventilator, you will not have that as a feedback. Remember, this is a very important practical thing I'm telling you. It will not be mentioned anywhere in the books. That's why I'm telling you this. समझ में आ रहा है मैं क्या बोल रहा हूँ? हाँ? Right. So now, if I give you an option, okay, you have this patient who is having this autoflow and it is causing hemodynamic embarrassment. You have to do something quickly. Huh? Will you touch I ratio? Will you touch RR? What will you do? Or tidal volume? You see that the flow is causing blood pressure to go from 140 to 110. Okay, you're seeing that. It's not cardiac arrest. Cardiac arrest, so we know. What we want to do? Disconnect, press the chest wall. We are not in that situation. What situation we are in? We are in a situation where the BP is dropping, flow restriction is occurring. Okay, I want to treat this now. And I have to use, bronchodilator is going to take its time to work. I need to take care of this quickly. So what do? Do I change I? Do I change RR? What should be the intensivist perspective here? What will you change? Or you change both?
I ratio.
Or tidal volume? You have all three in front of you. I ratio. Okay, tell me why.
Because it will give more time for the
Okay, so let's take that example. Sachin, why you say RR? Because you heard it in the past. From me. Why?
It's a time.
Huh? So let's take the ratio IE 1:2. Let's take another patient IE 1:2. Okay, let's take the RR here as 18 and let's take the RR here as 10. Okay, now I'm going to change the characteristics of this by changing my IE ratio. Okay, so now let's characterize this 1:2 at 18. What will be my breath cycle? What will be 18? 60 divided by 18 कितना आता है? Divide quickly. 60 divided by 18 कितना आ गया?
3.3.
Open 60 divided by 18
3.33.
कितना हो गया? हाँ? 3.3. Right? 3.3 is my breath cycle. Each breath is 3.3 seconds. Each breath is 3.3 ना? हाँ? 3.3 seconds. Now let's make it 1:2. हाँ? कितना है? इसका half कितना हो गया? 1:2 करो. उसको 3 parts में divide करो.
1.65.
No, 1.6 will be half. इसको 3 parts में divide करना पड़ेगा. So divide by 3 कितना?
1.1.
1.1 and 2.3. So my inspiration is how much?
1.1.
And my expiration how much?
2.2.
This is my final expiration after change. This is my expiration now here. I'm going to change my I ratio from 1:2 to 1:3 because this is what we wanted to do. We said let's change it to 1:3. Amit wanted to make it 1:3. Okay, we made it 1:3. Now कितना हो गया ये 1:3? ये 3.3 को change करो.
Divided by 4.
Divided by 4 करो. कितना आया? Divide.
0.7, 2.6.
0.8.
2.6.
Huh?
2.5.
0.8 and 2.5. So your expiration has changed by 0.3 seconds. Expiration changed by 0.3. Now I'm going back to this 18. The same 18. I'm now converting this from 18 to 10. I'm leaving the I ratio the way it is. Okay, I'm leaving the I ratio. This is what you're seeing. I'm not changing the I, I'm changing the RR now here. Okay, so this is how much? Breath. This was initially 3.3, it was 1.1, 2.2, this was what it was. Now I'm making this into 6 seconds. Now 6 seconds, make it 1:2, कितना हो गया?
2:4.
2:4. How much is the expiration?
4 seconds.
How much was it here?
2.5.
Which is better now? 4 seconds, no?
Second one.
This one is better, no? Because your expected time is more here. So what has helped? So what should be the first setting you change? Amit, samjha?
Yes.
You all understood?
Yes.
So if somebody asks you that this is a very important MCQ that comes in the exam. I don't know if it's still there in the exam, but this was one of the MCQs that you are on your rounds and you find that there is flow restriction. You have to alter a setting which is the best possible solution to getting the autoflow under control. They'll write tidal volume, they'll write I ratio, they'll write RR, and they'll write change mode. Okay, and the answer is actually change RR. Okay, but unfortunately you're so ingrained with this I in your mind, no, that you start, everyone writes of I. You know, so what, and everyone says also I. वो सचिन ने बोला कि उसने सुना इससे पहले. But at least he remembers that much. Good. हाँ, ठीक है? हाँ, clear on this? You understood this, right? It's a simple calculation. It's nothing but a simple calculation, right? So, now you've understood about how to reduce your intrinsic peak. You've understood that, right? How to reduce the intrinsic peak. Clear on this? Clear on this? So, how do you calculate the intrinsic peak? Inspiratory hold. So, when you do an inspiratory hold on the ventilator, each ventilator will have a different way that they demonstrate what your intrinsic peak is. You must understand what that ventilator is telling you. You understand what I'm saying? So, if you press plateau pressure, some ventilator may show P plat, some ventilator may show total PEEP, some patient ventilator may show PAWP, but different words will be there. You must understand what to look at. And the easiest option is what? Press plateau, freeze the graph. Press plateau, freeze the graph. When you press plateau and freeze the graph, when you drop it over here, your what call that, your cursor, you drop it over here. Whatever you get over here, that is your pressure. You get this to over here, this part, and check what it is. That's your pressure, plateau pressure. If you don't understand anything, clear on this? Plateau pressure. Some will say total PEEP. That total PEEP means what is your intrinsic PEEP? Your intrinsic PEEP is what? It will say total PEEP. When total PEEP, it means what? Whatever you are getting as plateau minus your peak pressure is your intrinsic PEEP. समझ में आया कि नहीं समझ में आया?
Can you speak peak?
What am I trying to figure out? What is my auto peak? Okay. What am I doing to measure auto peak? I am pressing expiratory hold. What am I pressing? Expiratory hold. That means I am holding it somewhere here. I am holding it somewhere here. Okay. When I hold it somewhere here, how the graph will look? You know, the graph will look something like this. The upper wala graph will look something like this. This is my peak pressure. Though I am doing flow or I am stopping exhalation. Though I am stopping exhalation, I am looking at the pressure graph. The pressure graph will go like this up. Now it's coming down, right? Supposed to come down, right? It will come down, and now you held it here. You held it here. This is what will happen. Because it's expiratory hold. When you do inspiratory hold, what are you going to see? And then you put your cursor here, and then this pressure over here, what you see over here is plateau pressure. Now what you are doing over here? You are doing expiratory hold. So I am pressing my expiratory hold over here, that is over here, and then the pressure inside the lung is what is showing off. So this pressure is what you are looking at.
Plateau.
It's not plateau. This is not to be. It's an expiratory hold, no? It's an expiratory hold. When I'm doing my expiratory hold, what is happening? Whatever pressure is lying from inside is coming out. When I'm doing expiratory hold, what is happening? ये मेरा ये है ना? It's an expiration. Okay, expiration में I'm expecting you ऐसा छोटा नहीं ऐसा बड़ा है. In expiration, what is happening in the presence of auto peak? This is no longer like this. This is like this. I want to figure out कितना है. Okay, so when I'm doing expiratory hold, it is not completely expiring. It is remaining because of the auto peak. This pressure is what I'm seeing over here, and that pressure is what is seeing over here. Are you understanding? कि वापस repeat करूँ. You understood?
Yes, sir.
Understood this, right? So for my auto peak, I am pressing expiratory hold, which is causing the flow to stop at expiration, and the pressure that I am seeing at that time is the auto peak. So the auto peak might show as total peak. So if I stop it and I get this, okay, let me take the example that there is a peak already I have added here, and this is how it is. I have added a peak say of 2. I added a peak of 2. Okay, that means this is why this is 2. And now I did an auto peak. Okay, but when auto peak, it will come down here and then go back again on top. So now what pressure you are seeing here is your total peak, of which this part is your extrinsic peak that you have added, and this part is your intrinsic peak. That's what I'm trying to tell. Ki total peak will be a combination of intrinsic peak and extrinsic peak. If somebody wants to understand what is your intrinsic peak, you require to have this part minus this part. You know, this whole minus this part. That means only this part. समझ में आ रहा है? You understood this? Intrinsic PEEP, so somebody asks you what's intrinsic PEEP? This is my intrinsic PEEP. If say for example this was 2 and this total was 10. What is my intrinsic PEEP here? 8. Okay, and that 8 on ventilators will show you how much volume is getting trapped also. It's called V trap on ventilators. Because of that, there will be a certain amount of volume that is getting trapped. So on all your ventilators, there are buttons. In the button you will see V trap. Okay, the V trap is the amount of volume probably getting contained inside which is not coming out. You understand? That's called V trap. Clear? So if your PEEP is 0, your V trap will be 0. Intrinsic PEEP is 0, your V trap will be 0. If your PEEP is somewhere high, there will be some amount of a V trap. If your PEEP is there, if PEEP is 0, it has to be 0. But if the PEEP is 2 or 3 or 4, there will be some volume that is trapped. Okay, you can actually look at that volume that is trapped and also decide your bronchodilator and see how it's working. So, clear on this? Understood this? Huh? Management of this COPD? Okay, this is air hunger, okay? Flow restriction. See, that's what flow restriction is all about. Can you see the flow restriction very clearly? Can you see it? Now can you see clearly the flow restriction? Clear cut flow restriction. Can you see that? Clear? Clearly you are seeing the flow restriction. This is flow restriction. Remember this waveform, okay? See, that is almost reaching the baseline, and it's what's happening out here is that you have probably bronchodilated this patient or something like that is kind of changed. Okay, so bronchospasm treated. See, look at the difference. Can you see the difference? See that? What has happened to the peak pressures? What has happened to the flow? Peak expiratory flow is increasing. What has happened to the baseline? It is reaching the baseline. So you are seeing three things here. When you are treating the bronchospasm, you have seen three things. We have treated the bronchospasm here. The same patient, and this is the same patient that we were looking at. You treated the bronchospasm. Immediately, what you have seen, the peak pressure which was 38 and 33 in the past has come down to 5. Okay, after the bronchospasm treated. The peak expiratory flow rate has kind of increased. It was somewhere at 12 or 10 or something. It has been 25 or 30 or something. It has become over here. Okay, over here. We're also seeing that the this is reaching the baseline. Reaching the baseline, indicating that my patient is getting treated. Bronchospasm getting treated. Clear on this? Clear on this? See that? That was on top. This is the patient. See how it is improved? It has improved very clearly. Right? Huh? Any doubts on COPD asthma? And then last part of the story is you continue this. So if you have intubated and ventilated the patient, don't try to wean him in 6 hours. Patient will be conscious, will be obeying commands. But don't try to wean. There's no point. Why you can't wean?
Because we are giving time
You have to give time. No. What happens unfortunately with most of the doctors are, you take the patient, you put them on the ventilator and they become like normal. They start becoming normal because everything is fine, your tidal volume is looking better, the peak pressure is starting getting better and everything. And then you decide, so let me start lightening the sedation, we can start weaning. You start weaning and again the whole pathology starts. Everything goes for a toss, auto PEEP comes in, patient starts triggering, starts moving in air, problems ho jata hai. So that means to say, if you have a patient who are treating with COPD or asthma, give him that 24 to 36 hours for that airway to get better. Give him that proposal. Don't immediately try to start weaning this patient. It's wrong practice. Similarly, BiPAP. You're putting on the BiPAP. Don't try to immediately come down on the BiPAP. Okay. You keep the BiPAP on. The pathology has to get cured. Then only you can come off the BiPAP. समझ में आ रहा है? हाँ, समझ में आ रहा है? ठीक है? So and weaning. When you wean these patients, you want to wean them only when you're completely certain about all these parameters that we're looking at. That's after some time, and preferably you would like to wean these patients onto an NIV. You will probably want to wean these patients onto an NIV, preferably. Okay, that's how it will be because the weaning rate are higher when you wean these patients. Because COPD is the gold standard indication for NIV. So if you're coming off the invasive ventilation on a COPD, not an asthma, in COPD patient, you will want to go into an NIV. So I'll extubate to NIV. That will be my orders. Extubate to NIV. Clear? Huh? Any doubts about intubation, ventilation and weaning in these cases?
So, what will be the PEEP setting in COPD?
Oh, we missed that. So what will be the PEEP setting? So on an average, we can understand that the PEEP inside the lung is there. That's why you're intubating.
Yes.
Why do you set a PEEP?
To
Open.
Keep the alveoli open. What is the situation here?
Hyperinflated.
So by definition, you don't need a PEEP. It's already open. Our reason to keep it open is because oxygenation is dropping. So let me keep my alveoli open. I want the oxygenation to improve. This patient is not the oxygenation problem at all. It's not that at all. So ideally, if you want, if I want to give 0 PEEP also, it's fine. Because what I will do, I'll put the patient on the ventilator, check my auto PEEP. If my auto PEEP is showing 5 and 6, it's already there, no? It's already there. I'll do the same maneuver that we were just now doing. I'll do the maneuver. Okay, I have set a PEEP of 0. This is coming down to 0 and then going back again on top. There is already an auto PEEP happening over here. You understand? So there is an auto PEEP there. You understand? If there is an auto PEEP there, why do I need to give any PEEP? I don't require it. But you need to give a PEEP. So there are 2 proponents to this. So some people do say that if there is some amount of auto PEEP that is inside, you give a tiny amount of PEEP, so that you can stent open the airways. That you have to take a call. Kaise karna hai? Okay, because that is what you are all about. Okay, you come bedside, you put a PEEP and you find the flow restriction happening and auto PEEP going haywire. It's not the right thing to do. Other way around, you have a patient who's on the ventilator, you're trying to get the patient off the ventilator. You want to take the patient off the ventilator, so he's not able to trigger. Now you understand why he's not able to trigger, because he's so much of auto PEEP in his body. Okay, any patient I want to try to wean this patient. Why? Because so much of auto PEEP is there. You understand? I will need to bronchodilate, get that better, isn't it? But if I want to make the patient trigger the ventilator, what will I need to do? I will need to add a small amount of PEEP, like how we discussed. Okay, and by theoretically it is 85% of your total auto PEEP, theoretically, but nobody knows whether that works or not. So we try doing it. It works. Sometimes it doesn't work. So theoretically it is 85% of your auto PEEP. So if you have 10 auto PEEP, your PEEP would be 8. Theoretically. Because if you put 10 and 8, then the patient needs to take only -2. You understand? He just needs to be -2 to trigger the ventilator. So -2 plus your trigger, whatever you put. You got to put a trigger of -2, then -2 is -4. You got the point? If it is 10, okay, I have put a trigger of -2 on the ventilator. The patient needs to go to -10, -2, that is -12 to trigger the ventilator. What I will do, I will add a small PEEP of, or at the airway, I will add a small PEEP of 8. So it has to go to 2, -2, that's around 0, no? Only -2, and -4. You understand what I'm saying? Then you'll be able to trigger the ventilator. So that is only if I want to make the patient trigger the ventilator. So these are those very difficult COPD patients who you cannot reduce the auto PEEP. You cannot reduce the auto PEEP. Okay, now you are in a situation where the patient is on the ventilator and this is a time that you feel that the patient has got better. I want to move this patient from invasive ventilation to non-invasive ventilation, and I want to see whether he is able to trigger the ventilator. That means his diaphragm is working well or not. Okay, because diaphragmatic dysfunction will not be able to trigger the ventilator. Now to understand diaphragmatic dysfunction, I have to remove my auto PEEP. So if I remove my auto PEEP, I'll come down from 10. Say for example, if my auto PEEP was 10, I'll start a PEEP of say 7, 8 or 6 or something like that, and see whether it's triggering the ventilator. If it triggers the ventilator, this means diaphragm is working when it's triggering. That is why what I do, I extubate this patient and put the patient in NIV. I extubate and put the patient in NIV. समझ में आ रहा है? I extubate the patient, put the patient in NIV because I cannot reduce the auto PEEP further. I've done whatever it takes to reduce my auto PEEP further. You got the point? Now I cannot do anything further. I need the NIV to come inside. What the NIV does? It does the same thing. It gives pressure from outside. So you are able to trigger the NIV properly. समझ में आ रहा है? You understand? It gives pressure from outside. So positive pressure is coming from here. So it's able to trigger because of the fact that positive is coming from here. You got the point? So it's negating the auto PEEP. It's the same concept. The concept is the same. You understand, no? That's why we want to preferably extubate them to a NIV. Because as she started by saying, COPD is an irreversible disease. So the auto PEEP will be there. If the auto PEEP is going to be there, logically speaking, you can't make the auto PEEP 0. You understand? It's an irreversible disease. So that auto PEEP को negate करने के लिए, I will need to extubate this patient onto a NIV. Clear this? Clear this? So classically, these are those patients who already are on an NIV. You know, so they are already on an NIV at home. So then you extubate and put same NIV back. Clear? Any doubts?